Today thanks, Ash. Today I'm speaking to you from Jackson Hole, Wyoming, where I spend my winters, which is part of the unceded land of the Bannock, Blackfoot, Crow, Eastern Shoshone, Grovant, Mountain Shoshone, Nez Perce, and Northern Arapaho tribes. And I'd like to acknowledge those people and their communities and pay my respects to their past, present, and future elders. We are recording, so if any of you do not wish to have your faces on the recording, you can go off video. Otherwise, I'm going to let Chris Price take it from here. And yeah, we'll see you after.
Thank you very much, Beth. Happy New Year to everybody. Glad that you could make it to this. I just want to kind of follow up in Dale's footsteps since she is kind of nicely sliding into retirement, kind of hopefully for her and enjoying her time off. That I was going to do the COVID and any kind of community health kind of updates. The data that we have so far is just as the end of last year. We usually run about a week to 10 days behind just because it takes time to correlate the data. So the data is the end of December 31st is the last date that's been reported so far. Just as a whole, yes, COVID is still around, but I just want to remind everybody that as in May of 2023, the WHO deemed that the pandemic was over, and it's now just an endemic, which means that COVID will be here and it's no longer in catastrophic things. A lot of news articles are still calling it a pandemic, and I just want to make that very distinction because it's no longer that according to the WHO. In terms of what's going on, most of the country actually is in a low section of COVID, unless you're in the deep south. That starts coming in about South Carolina, going all the way over to Louisiana, down to Alabama. Most of the places, there are some pockets in Idaho and also Eastern Oregon that are high spots, but most of it is in low. We are actually seeing a significant reduction in total cases in COVID. This year so far, we've had a total of 35,000 in the month of December. As compared to 2022, we had 98,000 cases. So there's a significant reduction, at least in that way, that the vaccinations are working. The new strain that's out right now is the JN.1. That's accounting for about 65% of the total infections. But there's plenty of things out there. There was also a recent article that said that Paxlovid is not being used enough by people over the age of 65, and those are the people at high risk. Only about 10% of people that are high risk are actually using it. And the reasons for that were because they got in too late or they're afraid of rebound. So those are the two things, but it is something that does help for people with high risk. And that's primarily people over the age of 65, the immunocompromised, and the usual sorts. In terms of RSV, that's the other new virus that's out there right now. Usually what we see, this is kind of it disperses itself between usually October and April of the year. There's a peak and then it tends to drop off in the other months. Right now, the total number of cases across the country is also down compared to the previous year. For example, like in the state of Washington, we've had 650 cases since in the month of December, whereas in 2022, we had 1,000. So there's a significant reduction throughout the entire country. The peak across the country was the second week of December, and we're trending downward across the country, so that's also a good thing. The final one that we have now is flu. Most of the country is at high risk, but every county in the country every year becomes high risk because that's just what it is. But actually, the total number of deaths, if we take example in the state of Washington, we've only had 16 deaths so far through the flu season. As compared to last year, we had 96. So there seems to be a trend downward. And what we're thinking that is that we've actually gone off the mask mandates and that we have a significant rebound of more infections the year after the mask mandates were removed, similar to what China is going through right now, since they stopped their no mask or no tolerance policy. So all in all, it's still out there. It's still good if you're high risk to take precautions. That's kind of where we are with COVID. Any questions about that? I guess not.
Do we
So
have an
I will.
update on shingles? I'm just curious.
Um, Interesting thing about shingles. There's no, there's no real data that follows it. But one thing I have read is that shingles is becoming more common nowadays since we started vaccinating our children for chickenpox. And the reason for that is what we're thinking is, or at least the thought that I read from a person at Johns Hopkins, was that we, for shingles or for chickenpox to actually occur, it has to get to your spleen and your liver for it to reproduce. So it gets into your bloodstream. It takes about 2 to 3 days after exposure to get there. If we are actually vaccinating people or vaccinating children, older people are now not being exposed to it as much and not having their immunity levels as high. So we tend to see more shingles. Back when I was in medical school, we were told that if you have, um, okay, I don't know what's going on here, but um, uh, if you had shingles at the age of 30, you were considered immunocompromised. Now it's becoming more and more of a commonplace because of the vaccine. So we think that the lack of exposure and the revving up of the immune system is causing more shingles. So, but do get your Shingrix vaccine at age 50. That does help prevent this. Because the worst thing about shingles, besides the pain you get, is the long-term postherpetic neuralgia, which can cause significant pain for a long period of time. So with that, I will hand it off to Gerda. Um, Dr. Gerda Massel is a board certified physician advocate. She's also a board certified physician medicine and rehabilitation physician. Her advocacy focuses on helping individuals with complicated medical problems, including spinal cord injuries. Her clients are often hospitalized or recovering in a rehabilitation setting. She writes a monthly blog called the Fog Light, that discusses the American healthcare system and also includes practical information that is really useful for advocates. You can reach Dr. Massel at Gerda at mymdadvisor.com. And to further ado, I wish to introduce Gerda, who's a good friend, and I'll have you take it off, Gerda.
I'm taking it off, baby.
I didn't mean it that way.
Hey, it's so cold here. I'm not taking anything off. I'm in New York. We have 13 inches of snow, folks. Um, so, uh, specifically, I understand the format of these is a kind of ask me anything format. So, I have no slides with me by request. For those of you who've heard me speak before, I typically come with slides, but I am happy to answer questions. Before we get going, though, I also want to say that this kind of thing works best when there's a bit of a dialogue. While I can talk at length about many things, it will be more interesting for you, especially if there's something that I don't know or I'm a little off base on, or you can add information to also chime in, because this audience has a lot of information. Every person sitting here has good information that would help the group. So from my point of view, I will enjoy other comments, thoughts. I might direct us a little bit back to something if we get too far afield, but I would enjoy extra comments as we go along. So that's sort of my style. From my point of view, feel free to ask questions. Chris is going to watch the chat and bring up questions as we go. But there is no script for this other than the topic is to talk about discharge planning options, levels of care, etc. So what would you all like to talk about? What's on your mind? And I'll let Chris moderate. I see we've got at least one hand. Chris, Ray's got her hand up.
Okay, Ray.
Yes, could you please explain the differences between LTACs, subacute, acute, and all these different rehab situations?
Yeah. So that's thank you, Ray. I wish I give you a nickel for that question. That is such a good question and so friggin' confusing to people. So when people leave the hospital, they can go to another hospital, but at a lower level. And those two hospital types are acute rehab and LTAC. And let's do them one at a time, and then we'll come to the others. Acute rehab is also called inpatient rehab, is also called IRF for inpatient rehab facility. That's the place that you gotta meet criteria of needing, tolerating, and benefiting from 3 hours a day. That's an inpatient rehab. That's where you get all the nice expertise of the people that have, the nurses have special rehabilitation certificates, the therapists are neurotherapists, and it's designed for the spinal cord injured, the head injured, and a smattering of other folks. And it is an intense focus program, and you've got to kind of thread the needle to get into inpatient rehab because you have to be sick enough, but not too sick. You have to need rehabilitation, but not have plateaued. But if you get there, if your client goes there, inpatient rehab is where the rehabilitation expertise really lies. And it's considered hospital. The other type of hospital level of care that people can go to is called LTAC, which is long-term acute care hospitals. Those hospitals were designed, 100 years ago for like the folks with TB and other problems who needed hospital level of care, but not a short-term hospital. So this industry of LTAC or long-term acute care hospital came up. LTACs are primarily for people with pulmonary problems. You get good medical care because you're going to get a rounding physician on a daily basis and often a rounding pulmonologist. They'll have some rehab, but not the same level of expertise. And often you can get dialysis. So an LTAC is for your super sick clients who still need hospital care, but not all the bells and whistles of a short stay regular hospital. I've got more to say on other levels, but before I go on, any questions about acute rehab or LTAC?
There's a
Okay.
question, Gerda, from Carol Reganetti about is an IRF the same as a SNF or skilled nursing facility?
Nope. So IRF, inpatient rehab facility, and LTAC, two hospital levels, and you've got the acute care hospital. So hospital, acute care hospital. Then you can either go acute care right to, I don't know, my name's in the way, right to SNF, which is subacute, or you can go LTAC IRF to subacute. Subacute is in a skilled nursing facility, a SNF. And the people that round there in skilled nursing facilities are called sniffists. So subacute rehab is where most of our clients go. Now, why do most of our clients go to subacute rehab? Money. It's cheaper, way, shall I say it again? Way cheaper to have somebody in subacute rehab than inpatient rehab. Everything's about the money. Ask me, I'll tell you. I know I do a lot of thinking and work and sort of the economic drivers behind the scenes. So subacute rehab generally now is a separate unit, not 100% of the time, but mostly is a separate unit inside a skilled nursing facility. For nursing homes, many nursing homes develop these subacute units. Why? Money. They make more money in subacute rehab than they make in long-term nursing home care. So subacute rehab is, if you've got Medicare, traditional Medicare, up to 100 days. And so the stays are much longer and they're more generic. So people with all kinds of medical conditions will go to a subacute. So for
Yeah,
example,
Can you give us an example? Sorry, Gerda. Can you,
That's what I was about to give you.
yeah, like a few anecdotes to help everybody kind of wrap their minds around the different patients and how
Yeah.
that.
Okay, so person has a stroke, right? Common thing that happens. They might go to an inpatient rehab first, or they might go directly to a subacute. And their insurance coverage and the PT assessment will depend on in the hospital whether or not they can get up and tolerate some therapy. It doesn't have to be that they're walking, but they have to be participatory and well enough to engage in 3 hours a day or more to qualify for inpatient rehab. If the person throws the therapist out of the room, is sort of lethargic, is not doing a whole lot, maybe follows directions, has an element of dementia, just not all that engaged, they'll get turfed to subacute directly, and they'll, won't bypass go, they won't collect $200, they'll go straight to subacute. Questions on that? I'll
We
give you
also
many other examples.
have-
Go
we
ahead.
also have another question about, does insurance pay for all of these facilities or such? I mean, are they paid by Medicare? Are they paid by private insurance? Is it paid by long-term care insurance? Is there differences between these?
Okay, so let's go in that direction, and then let's come back to examples. So don't let me forget to do examples. So the
Okay.
question was, does Medicare cover these different levels? Yes, it does. Medicare will cover all three of the levels that we just talked about: inpatient rehab, LTAC, subacute. Managed Medicare, which is when your clients have signed up to get that nice free gym membership and other things, will likely manage that rehab stay extremely tightly. Because in order to afford to give you a free membership in the gym and reduce your premiums, they got to save money somewhere. And one of the places that they save money is in rehab stays. And if anybody has been reading the news, it's been all over the medical news just in the last week or two that United Healthcare was found to be using very, very tightly prescribed algorithms to deny rehab stays out the bat. And they counted on multiple levels of appeal happening before they would then, agree to pay for subacute or other forms of rehab. So there's been some scandals in the Medicare Advantage industry coming out. But yes, in general, insurance covers these levels. Where people get into trouble and angry and upset is, and here's a classic example. I had a guy, early 70s, I say I had because he was a client of mine, very active, healthy, robust, early 70s, was like doing some work on an embankment, literally like working on the bank, and fell and hit his head on the rock below, had a traumatic brain injury, had barely 3 weeks in inpatient rehab, had a UTI, as people usually do, often do. Family said, okay, yeah, let's send him to the hospital. And then they couldn't get him back into inpatient rehab. And that's when the families are pulling out their hair. And that happens all the time. The inpatient rehab stays can get really, really truncated.
Gerda, can you, I know that there's probably a lot of people on the call that know about the sort of 4 disciplines that are involved in rehab, but I think it's important just to talk about that, like PT, OT, social work, speech.
Can I hold that question?
Oh,
and
sure.
Give some
Yeah.
other examples to finish up Robin's questions?
Absolutely.
I'm
Yeah.
going to write that down,
Okay.
PT, OT, speech. And I wanted to also, somebody in Chris's question asked long-term care insurance.
Yeah.
Let me just answer that, and then we'll come back to the patient examples, and then we'll go to you, Beth, I promise. Okay, so when it comes to long-term care insurance is for you, the family, or you, the person with a medical condition, to have less out-of-pocket expenses. It is not the same thing as health insurance that pays directly to a facility. It's about the expenses. And once that loved one comes home, boy, oh boy, are you going to have expenses, because insurance, and we can talk about home care in a minute if we have time, will cover far less than most people expect. So long-term care insurance is one way of paying for private services. There's other ways too, which if you want to talk about those, we can come back to them. Okay, Chris, have I finished that box of insurance questions? Okay,
Yep.
back to Robin. The question on other examples. So we talked about the person with stroke who may go directly to inpatient rehab, or they may go directly to subacute. We talked about somebody with traumatic brain injury who, as long as they can tolerate that 3 hours, is going to go directly to inpatient rehab first and then step down. Now, somebody that's likely to go directly to subacute is going to be a bout of congestive heart failure, hasn't gotten out of bed for a few days or a week, and now they're not at their previous baseline, and they need to recover from the hospitalization. A gazillion years ago, and I am so old I remember these days, you recovered in the hospital. You do not recover in the hospital. You are sick as stink, you are sick, and then you go to subacute to recover. That is generally the path most people take. They used to go home to recover, but they were already partially recovered. Now most people go to subacute. For an and you could be sick as stink with anything, just congestive heart failure, community-acquired pneumonia, any reason that somebody is hospitalized, syncope, anything. I'm sure you could all think of a million reasons. LTAC is going to more often look like either COVID on event for a while, now still on event, but they need to really have a trial at weaning that might take several weeks. They go to LTAC. Could be somebody that, I think of a client that a recent client who had a heart valve surgery. And then on the other side of the surgery, they were delirious and partially weaned from the vent. But the acute care hospital said, yeah, she's stable from our point of view, but she still needs to come off the vent, and the delirium needs to go away, and there's a few other things. She went to LTAC because of the ventilator. So let's just, and then we'll move on to types of therapy. Other levels of care, like patient profile kind of questions or examples needed.
Can you please give an example of cancer? Since my sister-in-law just got diagnosed, and she's going to be, she's got 4th stage. She's going to be going in and out of the hospital. She's 60 years old. What happens? What do you see around cancer, since it can be such an in and out kind of game?
So cancer is such a broad category that the answer can be yes to all of the above or no to all of the above. It truly depends on what that individual needs. Most people, cancer care has changed dramatically over the years, where, I remember when we used to have whole cancer wards. And now, because so much of the cancer care is through pill or infusion, whether it's an immunotherapy infusion or a chemotherapy infusion, a lot more cancer care is done in the home environment, which frankly is better for the person, or the outpatient, the non-facility environment, which is frankly less nasty bugs that you can catch and more comfortable. But a person with cancer could end up in an inpatient rehab if, for example, they had brain mets, but were still functional enough that they could benefit from 3 hours a day. More often, if they're going to need facility care, they're likely to end up in subacute. But in general, they're going to stay in the community as much as possible. Go to hospital community. Did that answer your question, Kate?
Yeah. I know that we're just talking mainly about people who are on Medicare, right? Is that right?
It can be anybody. The same basic rules apply.
Oh, okay. Thanks.
And I'm sorry about your sister or sister-in-law?
It's my sister-in-law, and then my nephew's got melanoma. I mean, I just know about 4 people with cancer right now. It's crazy.
I'm sorry, that's
Oh,
hard.
thanks. Yeah.
Patsy, you had a question? Oh, you have to come off mute.
Thank you. I was a little late to the show here.
That's okay.
So we've got three things. You move out of hospital to acute rehab to LTAC, or we can move to skilled nursing facilities. All are paid by all get some Medicare money. Medicare will pay for all 3. I'm reviewing to make sure I have this right. And is it true that it is 100 days of treatment under Medicare at any of those 3 facilities? Okay.
I'm
So-
glad you asked that question because it's
Okay.
confusing.
All right.
The famous 100-day benefit is a subacute benefit.
Okay.
Inpatient rehab and LTACs are usually weeks under Medicare.
Okay.
So they're not 100 days each, it's weeks.
Okay. Thank you. And then I was sent to a subacute situation recently, and I thought I was being sent to an acute rehab.
I bet.
And I was disappointed at the amount of rehab therapy I got,
Yep.
because I didn't know the difference. So I first of all want to thank you in this session, but second of all, how when I needed to get out of the hospital, they wanted me out, and decisions had to be made fast, and I got very little help.
Yep.
What can we do there as advocates for ourselves or somebody else? Okay.
So I'm going to park that question too,
Great.
which is DC planning advocacy, because I want to finish up on the topic of levels of care and the difference. And then we'll come back to discharge planning advocacy. The quick answer is there's lots you can do. But
Gerda,
let's go back.
could I jump in? My name is Adrienne. I'm a senior housing advisor, and the 100 days thing is I run into it all the time. People have to be careful. I get clients all the time that say, well, I have 100 days, or my loved one has 100 days.
Right.
You have 20 days at 100%. You have an additional 80 days where you copay about 20%.
Yep.
Only if you're progressing. So that person with dementia who's no longer participating, someone is plateaued, the Medicare will dictate to the SNF, it's time for them to go. Now they can stay if they want to pay 100% on their own. But there's a big misunderstanding in the industry, or just the few people that know anything at all. They hear the 100 days and they think they've got all of those. They don't. And be really careful with, I get that all the time. Oh, somebody told me it's 100 days. No, only if you're progressing. So I always want to jump in because so many of my clients, I'll have them, we're being discharged in 3 days, Adrienne, what do I do? Well, I got you, but there. Thank you.
So that's a perfect example of the audience coming in with an excellent point. So thank you for making that point. That's spot on. And what she was talking about is the copay increases and the scrutiny increases with every passing day. And it does it not in evens, but it's 20, and then it goes in increments from there. So thank you. That's absolutely right. The benefit is up to 100 days, and the reality is that it is more variable by facility and person interpreting it than you might think. So I have seen people kept on in facilities where they really work hard to tweak, and this is traditional Medicare, not managed Medicare. Managed Medicare is a whole different ballgame where it's going to be short no matter what you do. But under traditional Medicare, there is a certain amount of tweaking that some facilities will do of their documentation to justify the 100 days. But back to the money, they get paid less money the longer somebody stays. Their rate essentially on a daily basis is lower because of the way the fees are set up. So in a facility that is a high turnover facility with tons of Medicare patients knocking on the door, they have less motivation to adjust their documentation in a way that looks like the person is progressing and has additional goals. That's just my opinion. It's reflecting what I've seen.
And
Adrian, other
Gail has a
comments on that?
question.
I just want to go back to Adrian for one
Oh,
second
no
to
problem.
see. Have you seen anything different than that? Where
No, that's spot on. I just, obviously, there's so little information out in the marketplace that most of our clients don't know anything at all, but they get snippets. And so, oh, my sister was able to stay 100 days, so my mom can, so I can be a little relaxed about this. She's being cared for. And then all, you know what breaks loose when they get that discharge notice or the you're paying 100% notice. And it turns into a scramble. So that everything you said, yeah, absolutely.
So I
Okay.
just wanted to point out, I get a lot of people who say, oh, I get 100 days. And I tell people the key words are up to. Most people get 14 to 21 days, I believe. And then I also wanted to, like, everyone should be familiar with the Jimmo case, because you don't actually have to be progressing. You can get therapy to maintain your level of function or prevent decline, but even all these years after Jimmo, the facilities don't seem to know or honor that in many cases. So that's
So-
where our advocacy is really important.
I'll give you my own take on Jimmo because it comes up a lot, which is that the subacute environment is different than the long-term care environment. Jimmo, I think, is much more useful to bring up in long-term care where you're talking about maintenance. In subacute in general, they're looking for progress. And so Jimmo is harder to apply. In long-term care, yes, it's easier to bring it up. That just sharing what I've seen. And there is a difference, and not everybody always parses that. Okay. Other levels of care comments?
Whilst we're on topic, can I just clarify quick? So demo, since we talk about the money side, the SNF may be less motivated to pay after 20 days, 21 days, whatever. So even though per demo, they might be able to stay without too much progress, they may have to pay more. Is that correct?
That's not related to Jimmo. Jimmo is a case that talks about whether you can get coverage from Medicare for maintaining somebody's function. Medicare system is set up for all subacutes to pay differently at different intervals. And the first interval goes 20 days, and then I can't remember, and maybe somebody here knows, then it changes over time. So
Right.
their payments drop incrementally with time passing.
Right. So that's why, as an advocate, we have to be aware our clients may be able to stay, but still have to pay higher amount. Is that correct?
So people, yeah, if somebody stays and they almost always then switch into a designation of long-term care that they're then paying privately for.
Right. Okay. Thank you.
What if they have a Medigap plan? Does that make a difference?
Medigap just follows what Medicare is doing. No, it
Okay.
doesn't make a difference.
Gerda, after I left subacute care, I went into home health. Could we talk about home health briefly?
I'm going to put it on
Would
the
that be
list.
helpful?
So what I want to do, so what I would like to ask the audience, if you can hold on. So these are all great topics, but out of respect for people that asked questions earlier, if
Sorry.
you don't mind, I'm going to go back to the earlier questions. Let's answer some of those, and then as time permits, and we can always do this again. If this is a hot topic and you guys want to talk some more, it's fun. I love talking about this stuff, and I like meeting everybody. So we don't have to get every related rehabby kind of topic out. But what I have right now is PTOT and speech and the difference. I saw, but I haven't heard, somebody brought up subacute vents. So I do want to touch on that. How to advocate for discharge planning and home health. That's what I have as upcoming topics. Did I miss something?
Nope, I think that's everything. I think we need to kind of just stick to this main topic. And if we need to have a secondary, including the home health thing, we can have it as a second community conversation and things like that. So like to just get this first part done that, that you've agreed to do it. So,
But I'm excited that people have so many things they want to talk about. So I really appreciate that. All right. So to go back to the PTOT speech question, I want to make sure you guys just have a general understanding of what each of these therapists do, because, you know, they're going to interact with your clients and it's good to just have a framework. So PT and OT, you see different ways, and literally different teams of PT and OT in facilities will divide things differently. So sometimes they think about it as PT does the exercises for the upper body and OT does the lower body. I've seen that kind of line in the sand. If you take a step back, physical therapy is often about mobility. It's about sit to stand, walking, strengthening exercises, sort of as a field, just very, very broadly. OT, occupational therapy, is about the things that occupy your day-to-day, meaning ADLs, your activities of daily living. So OT is generally thinking about toileting and dressing and washing up. But if you think about it, you know, when it comes to mobility, well, a toilet transfer, can you get on and off the john, is pretty similar to can you get on in and out of bed. And so different places and different teams divide up the works. Usually the PTs leave the toileting to OT no matter what. But transfers as a general category can be commented on by either. And if you don't know, a transfer is just going from one type of surface to another, a bed to a chair to a walker. A transfer just means you're transferring your physical self in space. One thing, and in some places, PT focuses on all mobility and exercises, upper and lower body. OT does more of the ADLs. And in some neuro rehabs, OT does cognition. Now, you're not going to ever see an OT do an OT cog in a subacute, or very rarely. But OT cog is an important part in a good inpatient rehab, because there are things, have you guys heard the term apraxia? So sometimes you can have the ability to move, you know, you've got the strength, but you can't put it together to do the task. So you might have upper body strength, but you may have a dressing apraxia. You can't get dressed, and that's where OT cog can come in. OT cognition looks at some of these neurologic functional interfaces. So that's PT and OT. Before I go to speech, any questions on PT and OT? Whew, that was really clear. All right. So now speech. Speech does a couple of things. And if we were face to face, I'd have you guess. But since we're not, I'm just going to throw out a few. Well, speech does language and communication. It's called speech therapy. But it's not just talking, it's also understanding language. Well, talking also involves the coordination of your mouth. So some speech therapists get very involved in slurring and other issues that are a little different than the common communication issues. Well, now since speech is already thinking about your mouth and the coordination, they naturally become the swallowing people. So frequently, before somebody's allowed to eat, they call in the speech therapist. And by the way, the abbreviation for speech therapy is generally considered not to be ST, but SLP. So I'm going to say it again, not ST, but SLP, for speech language pathologist. So the speech therapist does language, they do swallowing, and then they also sometimes do elements of cognition, but more in the language cognition. Some speech therapists will get involved in things like, can they follow a multi-step command? You know, there's just varying abilities, both in OT and speech, to get involved in aspects of cognition. In general, especially in subacute, you're going to see the speech therapist do almost entirely swallowing work with some language work. Questions about PTOT speech?
Gerda, I wanted to just comment, I put it in the
Sure.
chat that those three plus social work meet and have conferences on the progress of the patient. And that is where I think advocates can be very helpful, getting involved in those conferences, knowing when they are, and directly communicating with all those different disciplines. So just, we've had a lot of those with our client base when Robin and I had the business. And I just think it's really important that advocates be there, be in the room.
Yeah, well, and one of the things that is so cool about the world of rehab is it's a very team-based discipline. So the subacute world, inpatient rehab came first and subacute grew later. In the world of inpatient rehab, you had team conferences twice a week. And it wasn't just PTOT speech and social work. The physician came and nursing came, because there's a lot of overlap between especially OT and nursing care. And when you're starting to do bowel and bladder programs, the input and the cross collaboration between nursing and therapy is hugely important. So, but even in subacutes, team meetings of different sorts will happen. In some places, they'll be overt about it. In some places, they won't be. The more the place emphasizes throughput and profit, the less you're going to see team and family meetings. But you can always ask for one. And when families ask for a team meeting, they may get a representative. They may not get, PTOT and speech. They may get a report in the hands of somebody who's reading for the others. And you may or may not get nursing. You'll always get social work because it becomes their job, or social work in this case is usually care management / discharge planning. It's their job to organize it. So you'll get the social worker, and then you might get a nurse. You usually have to specify if you want the doc or the nurse practitioner who's available. And then, the others depends. But I love team meetings. I think they're incredibly important.
So in the
Okay.
instance of time, I think we should possibly move on to how can advocates help facilitate getting into these different levels for the patient, from the discharge from the hospital to these acute rehab and subacute stuff.
So the advocate, unless you happen to be, have a strong rehab background, it can be tricky for you to influence what level of care. But what you can do as an advocate is to advise your clients so they understand the difference. Somebody brought up before how rushed they felt. And that, unfortunately, is the norm, not the exception to the rule. Discharge planning can happen very, very fast. So the typical process is somebody looks like they're going to be a day or two, 3 days from launch. They call in PT and sometimes OT, who comes in and does an assessment. I want to look at that assessment personally, because the skill of the person doing that assessment can be really variable. Sometimes they walk in, take one look, poke the patient a little bit, and they walk out the room, and then they just say subacute. Other times it's a much more thoughtful evaluation. And if you happen to have a client that you think should go to acute rehab, but they're there and you're concerned that the person in the bed may not be seen for who they are, and you guys, will know this, there are just certain people that kind of get ignored, whether it's because they're older, they have dementia, they're a person of color, they're a female, whatever reason. But in those cases, you may want to ask to talk to the physical therapist, or you may want to look at the record and see what it is they're thinking. And then explaining to your clients, and then often helping them select, especially when it comes to subacute, there's going to be a wide variety of choices in their geography, and helping them find and know how to choose can really reduce somebody's frustration when they feel like they're not alone in that process.
Karen, you have a question?
Yes, well, a comment actually. It has been my experience as an RN patient advocate that if we meet with the discharge planner, we have information that they do not have oftentimes in our intake. And that can make their discharge planning far more focused.
Excellent point. I think you're spot on, Karen. Talking to the discharge planner is often the difference between a safe and an unsafe discharge. Because so often the discharge planner only has a little piece of information, and you happen to know that they live alone down a dirt road, and there's no friggin' way Instacart's going to show up with that grocery delivery. But the discharge planner may have no clue.
Yes, it has been my experience, and they're always really happy to see you.
They're not
Also,
always
they're-
happy to see me.
Also, their job is to clear that bed. And it's not always in the best interest of the client. It is in the best interest of the facility trying to clear that bed. So making sure that we advocate and slow them down and do what's right is important, because I don't think we're working at odds with them, but we're not always working in tandem either.
Well, that's 100% correct. And, so talk about economic drivers. The one person that I see my clients get most ticked off at in the later phase, in the woulda, coulda, shoulda phase, is the discharge planner who rushed them out the door. And that's because that nice discharge planner, they thought the discharge planner was there to help them find the right place. And they were so nice and they seemed so supportive. And I'm not in any way saying that there aren't nice, decent, patient-loving, patient-centered discharge planners. There's plenty of them. But their job is move them in, move them out, move them in, move them out. Yeehaw, their job is turnover. And that is their economic, their incentive. Their job is all about getting your client out the door as fast as possible, whatever that may take. I mean, discharge planners before DRGs hardly existed. And by the way, it's not just discharge planners. I don't know if you know, there are other set of people behind the discharge planners, including utilization review people, physician advisors, and other people that are all part of the hospital infrastructure that exist to get them in, get them out, get them in, get them out.
Well, I'd like to add one more thing. There is actually an RN who has addressed this problem and meets with the case manager. Her name is Kathleen Sloan. She is an RN. And what she's been doing for years is working with the doc, discharge planner, and she will go home with that patient for usually one day, sometimes two, to make certain that they get all the community connections, that they understand the meds, that they understand treatments. It's a beautiful program, and I know she'd be happy to speak with you about it.
Yeah, nice. That's nice. Okay, so did we cover enough on that, Chris, that you, or other things you want to talk about what advocates can do?
No, I think that's perfect. We'll let you continue with your,
My rant. I'm here to rant.
you said it, not me. So.
Yeah, that's okay. I just wanted to touch, I saw, because I don't really get to see the comments, but I saw somebody mention, do some subacute units take care of people on vents? And the answer is yes. They are specialized subacute units that have a special financial arrangement, typically with the state, to take people on vents. They try to wean people, but it is, really tough. So if you're in an LTAC and your loved one's in an LTAC, and after a month or a little longer, they don't wean and they're still on a vent and they need long-term care, they'll step down to a subacute vent unit, which, there's only, they're geographically scattered, you have less choice, and the care and funding is much more like subacute than it's going to be like hospital. So families can get very frightened at some of the subacute vent units. Okay. Chris, do we want to go on to more on discharge planning advocacy, or did we kind of talk enough about that?
I think we talked enough about that. That should be good. And all, so yeah.
Okay, so then someone had asked about talking about home health. Do you
I
want
think
to
we
talk
can
about
leave
that,
that
or do
to
you
a
want to
different,
take
I think that's a
questions?
whole topic within itself. And I think we
Okay.
can just leave that. I mean, we could spend an hour or two on home health by itself. And I think that that would lead to another great community conversation. So we'll park that for another month.
Okay. Do we want to wrap up? Do we want to take some questions you see in the chat? You are large and in charge. What should we do?
I think just basically, I think uh, just kind of reviewing everything that you said before would be a good thing in terms of all the terms, just so we have an idea of what this is. I mean, I know we have the hospitals, we have, the high level outpatient, or inpatient rehab, and just kind of going through that one more time so everybody understands the different levels, because I know that Margaret was asking for that to be kind of reviewed once again, just to kind of, so we have a good basis. And then after that, we could ask, one or two questions and call it at that. So,
Okay. So I'm going to do, my hand going down, the highest level of care is the acute or short stay hospital. And when I say highest level, what I'm talking about is daily physicians, access to specialists, on-site testing. And while we're talking about acute care, keep in mind that not all acute care is created equal, right? You have community acute care and you have academic acute care and things in between. And so a community acute care hospital is not going to have all the bells and whistles and specialists and services that a academic or tertiary hospital is going to have. So even within the world of acute care, there's a lot of differences, and community hospitals are terrific for common problems and less terrific if you have something that's unusual. So acute care. And then less resources, but still hospital, are both LTAC and acute rehab, or inpatient rehab, or IRF. So LTAC and IRF are considered hospitals, but they have different focuses. IRF, inpatient rehab, acute rehab, focuses on rehabilitation, 3 hours a day or more. That's where you get the real deep rehab expertise, but unfortunately at times quite short stay, meaning weeks. LTAC has the expertise on ventilators and super sick people, that may be weaning from ventilators, may need dialysis, they're really ill, and they're just a long-term acute care hospital. And so they have less resources than acute care, but they still have way more resources than subacute. Subacute is going to be a unit in a nursing home, where you're going to get a nurse practitioner, typically rounding, sometimes a doctor. There's certain visits that are required by a doctor. You probably won't see daily rounding unless the person is ill. And you're going to have less intensive therapy, less skilled, and I'm not saying unskilled, but less skilled nursing staff, and more care by aides and people that have less training. And it's a much less expensive environment. And then if we want to say below that is facility-based long-term nursing care, nursing home care, where it is really more, that's where the person lives. They might still be recovering a little bit, but they're fundamentally done with the major rehabilitation stretch of their recovery. They might still get services. You can get services in long-term care, but you get less.
well, thank you. That's a great summary. One question that we do have in the thing is just a specific example. What if someone with a stroke has aphasia, and how do we actually see if they're actually cognitively there, and to make sure that they go to the right place post-discharge?
So if somebody only has aphasia and they're walking and there's no swallowing problem, they may not even need a facility. Occasionally you see one of those. Most of the time the aphasia comes along with other things come along with the ride. You know, there may be weakness, there may be swallowing problems, and they're not safe and able to go home. So when it comes to aphasia, an easy thing to do to see if somebody's sort of awake and alert and following commands is you point to them, you point to yourself, and then you try to get them to do something. And most people, if they can, they understand you want them to mirror you, you know, will do so. Most people will follow a visual command, even if they cannot understand a verbal command. You know, you could put your hand out for a shake to the less involved side and you see if they move. You know, doesn't mean they're understanding you, but it means that they're interactive. They're not just completely there. Just because you've lost language doesn't mean you're not present.
So let me interrupt here because I'm the one who put that in the chat. My name is Beth Barnett, and I had a case where a family member wanted to have the patient declared incompetent. And through that experience, I learned there's something called an adaptive competency test. And because the person had aphasia, I was able to advocate for them to get an adaptive competency test and document that they weren't cognitively impaired, they just weren't able to answer the questions because of aphasia. And that's something that you get through a speech and language pathologist.
That would make sense. Cool. Thanks for bringing that up.
Well, to respect everybody's time, we're at time right now. I wanted to thank Gerda for this wonderful presentation and the great questions and comments that have come from everybody. I wanted to also remind everybody that we have the case review on the 18th of this month for all advocates. That will be at 5 o'clock Eastern time on the 18th, where Rebecca Acosta will be presenting a case. And we look forward to seeing you again in a month for the next community conversation.
Sorry, before you go, Chris, because look, you're just about to sign off. I just wanted to invite, you know, anybody who has a case where you've got some medical questions, just reach out to me. I help advocates all the time. I'm happy to answer questions. You can email me. My standard email is gm@mymdadvisor. And if you're interested in my newsletter, if you just, again, I'm not trying to build Instagram followers, but if you want my newsletter, gerda@mymdadvisor.com. So I'm happy to help you. And sorry, back to you, Chris.
No, that's where I was going. You beat me to it. So, no, I mean, I actually think your blog and your newsletter is wonderful. I read it each time it comes out, and it has a lot of great information in it. So I highly recommend it to everybody here on the call. But I just also want to make sure that, you know, we respect your time, because I know you have patients in the hospital too, Gerda, and your time is precious. So, yeah. So thank you very much for everybody coming. And we will definitely probably bring Gerda back when she has time to talk about more of this, since it was such a great turnout and all of that. Thank you very much, Gerda. I really appreciate, or we all really appreciate you coming.
Always.
Sharing
For
your
you,
knowledge.
Chris, anytime. Happy to.
Well, thank you very much. And I will let you guys go, and hope to see you at case review, and go from there. Okay. Thank you very much, guys.
Thanks, Chris and Gerda. Bye.